Planning for the Next 5 Years, featuring Dr. David Mccory, the Associate Director for Prevention and Director of the Office of Disease Prevention at the National Institutes of Health. This webinar is the second of the 2014 ASPPH Presents monthly series, which has been designed as a service to CEIF-accredited ASPPH member schools and programs of public health. A few housekeeping items of note. While you are in listen-only mode and your lines have been muted, we encourage you to ask questions throughout the presentation by using the chat or question box. Please be sure to refrain from placing your line on hold during the webinar. This webinar is being recorded and it will be available along with the slides on the ASPPH website in the archived webinar section soon. Additionally, this webinar has been approved for 1 hour of CPH continuing education credit. Our speaker today, Dr. David Mccory, has spent his career evaluating intervention programs designed to improve the public's health. Over the last 25 years, Dr. Mccory focused on the design and analysis of group randomized trials in which groups are randomized to conditions and members of those groups are observed to assess the effect of an intervention. Dr. Mccory served as the first chair of the Community-Level Health Promotion Study Section, which reviews many of the prevention-related group randomized trials submitted to NIH. After 35 years at the University of Minnesota, the University of Memphis, and the Ohio State University, Dr. Mccory joined the National Institutes of Health in September 2012 as the Associate Director for Prevention and Director of the Office of Disease Prevention. In this role, he is responsible for promoting and coordinating prevention research among and between NIH institutes and centers and other public and private entities. Thank you for being here today, Dr. Mccory.
Thank you very much. Very happy to be here and have a chance to talk with you all about the strategic plan that our office released just last month. I'm going to talk with you a little bit about our Office of Disease Prevention, just to give you a little background, try to be brief with that so that we can focus on how we put the plan together, what the strategic plan has, and to talk about possible collaborations between the Office of Disease Prevention and you. This slide gives a conceptual picture, at least, of NIH. We have 27 institutes and centers, most of them involved in making extramural research awards. The circle that's sort of the center of that semicircle is the Office of the Director, where my group is located. The Office of the Director is a coordinating group. Dr. Collins, of course, is our director. We worry about trans NIH issues, issues that affect many of the institutes and centers, and that's where we are located. More specifically, we're in the Division of Program Coordination, Planning, and Strategic Initiatives. Had to learn how to pronounce that acronym soon after arriving at NIH, so DPCIPSI. We, along with the Office of Research in Women's Health, the Office of AIDS Research, the Office of Behavioral and Social Sciences Research, are program offices within that division. We work together, we help each other, and we are responsible for various areas that cut across all of NIH. The Office of Disease Prevention has been around for quite some time. It was created in 1986 following the Health Research Extension Act of 1985, which created my position. The Prevention Research Coordinating Committee, which had been in existence prior, was moved to the office. The Office of Dietary Supplements was created about 10 years later and placed in the office. We have a series of programs that have been in the office for some time. The Robert S. Gordon Lecture is one. This recognizes people who've contributed significantly to the field of epidemiology. It's an annual lecture. The Medicine Mind the Gap seminar series is an opportunity to present often methods research or methods topics to the NIH community to try to help them stay current on methods activities. And my emphasis, of course, in this area is on prevention. The evidence-based methodology workshops began in 2012 at about the same time that we were winding down the consensus development program. So the Consensus Development Program was retired last year. The evidence-based methodology workshops are somewhat smaller in scale, but still do evidence reviews and provide a forum to come together and talk about important issues in prevention research. Those were renamed to the Pathways to Prevention workshops, and that will be their name going forward. The most recent element of our office is the Tobacco Regulatory Science Program, and many of you are familiar with this because a number of you have T-Cores. These were large P50 awards that were granted last fall. We may see many of your faculty coming to our meeting in April, the next meeting of the T-Cores. The Tobacco Regulatory Science Program more generally was created as an initiative, collaborative initiative between FDA and NIH. FDA, following the Tobacco Control Act, was given regulatory authority over cigarettes, roll-your-own tobacco, and smokeless tobacco, and the authority to deem other tobacco products to be under their regulatory authority. And they're actually working through that process right now. They collect user fees from the tobacco industry, and those funds are transferred to the Treasury, and from the Treasury to many of them to us, to support research on tobacco regulatory science. And NIH awarded over $100 million in new research projects under that umbrella last year, and the figure will be higher, I'm sure, in 2014. So when we think about what the Office of Disease Prevention is today, we co-fund NIH research projects. We sponsor meetings and workshops that support prevention research. As I said, we have the Tobacco Regulatory Science Program. We serve as liaison for a number of important activities, including Healthy People 2020. We coordinate that across NIH. We're the liaison for the National Prevention Strategy, for the U.S. Preventive Services Task Force, and the Community Preventive Services Task Force, among others. I mentioned some of our evidence-based assessment programs and some of the training and education programs that we offer. So these are some of the activities that have been in place at the Office of Disease Prevention for some time, though the Tobacco Regulatory Science Program is quite new. When I was considering this position, I asked to see a copy of the strategic plan for the office and learned that there wasn't one, and there hadn't ever been one. And though I was never especially a fan of strategic planning, I thought this is an ideal opportunity to use that approach, because I was coming in with lots of ideas that I wanted to pursue, but I didn't feel comfortable directing the office strictly down a road that I was going to map out. I wanted input from the community, wanted input from others, and the strategic planning process seemed like the perfect way to do it. So we started that process a little over a year ago. We had a working group of NIH and other federal and extramural and public partners to guide the process. I met personally with all the institute and center directors and talked with them about things that we wanted to do, and got their thoughts on what our office could do to help them do a better job with prevention research. Out of that came a revised definition of prevention research for our office. We're focused on primary and secondary prevention. We're interested in research that promotes health, that prevents the onset of disease, disorders, conditions, or injuries, and detecting and preventing the progression of asymptomatic disease. We're interested in research that targets biology, behavior, factors in the social and physical environments, and health services. And again, it's all about primary and secondary prevention. It's a fairly broad definition, but a bit narrower than the definition before I arrived. Our mission is to improve the public health by increasing the scope, the quality, dissemination, and impact of prevention research that's supported at NIH. So that is our task. We are tasked with worrying about prevention research all across NIH, all of the institutes and centers, without focusing on a particular disease entity or a particular health problem. We are a small office. I have about 22 staff at present. I hope that will grow to 32 or 34 over the course of the next year and a half. But even then, we will be a very small office with limited resources. We are only going to be successful by working closely with the institutes and centers, who have much, much larger staffs and many, many more resources. And we intend to work closely with them, and have been before I arrived, and certainly since I've been here. We want to extend our value as a resource to the NIH community, to the broader prevention research community, and we hope to do that over the next 5 years. Building on the revised definition and the new mission and vision statement, we sought input all across NIH to guide the development of priorities and measurable objectives and activities and timelines for our strategic plan. We met with literally hundreds of program and review staff. The public participated through a request for information. We talked with a number of professional societies and lots of extramural investigators. And we organized that input around a set of what started out as 8 draft strategic priorities was distilled down to 6. We had a team working on each, and they made recommendations to me on the priorities and candidate objectives, tasks, benchmarks, and timelines. And the strategic plan then was approved by Dr. Collins in January 2014. So we were certainly free to come up with any strategic plan that we wanted to come up with, but it had to have the stamp of approval by the leadership at NIH before we could release it and start to pursue it. So this has been fully accepted by Dr. Collins, accepted by the Institute and Center directors. We have 6 strategic priorities, 19 objectives. We have 5 years to make some progress, and all of you can find the plan on our website. Now, the first priority, and I'm going to go through the 6 just briefly. The first priority is to monitor investments in prevention research and assess the progress and results of that research. I was perhaps naive before I arrived and soon after I arrived, thinking that the National Institutes of Health ought to surely be able to accurately describe the extent of the investment in prevention research and be able to easily generate figures and tables showing me how much we had spent in this area using this particular kind of research approach, working or focused on a particular topic and so forth. And I discovered, in fact, that we couldn't do any of that, at least not very accurately, with the current tools that are available. I was also convinced pretty quickly that trying to fix the current system was probably not an approach that was going to yield satisfying results, and certainly not very quickly. So we have taken on the task of trying to develop new tools that can do a better job. We have established a taxonomy for prevention research that we will start to use later this spring to classify awards made in recent years. We will do that by hand initially, not necessarily a happy task, but we're going to employ a lot of your students, especially those at Maryland and GW and Hopkins. We'll be recruiting them in the next few months to start working with us on this project. And we're going to be coding thousands of awards using our new taxonomy. We're going to use that coded information with colleagues in the Office of Portfolio Analysis, also in the Office of the Director, to develop new software tools that can do the coding automatically. The last thing that we want to do is get into the long-term business of coding awards by hand. That's rather old-fashioned. We hope that the new tools will be able to classify awards according to our taxonomy, and if we're successful, they'll be able to do that going forward as the taxonomy evolves, and retroactively applying the taxonomy in whatever form it exists to awards made last year, 5 years ago, whatever we have available to us electronically. Once we have that system, then we're finally going to be able to generate the kinds of tables and figures that I wanted to be able to generate on the first day, which is how much money are we spending on randomized clinical trials in obesity in this age group or in this population segment from these ICs, and what do those trends look like over time? Are we starting to fall behind somewhere? Is there an area where we're not doing enough? I just don't have good, accurate data to address those kinds of questions, but we hope to once we finish developing this tool. The next part of the process then, once we have the tool, will be to regularly look at how we're doing and try to assess the results of the investments that we're making and identify areas where we need to make larger investments. The second priority is to identify prevention research areas that need additional attention. ICs look to us for advice on areas that they should get into. I heard that from every Institute Center director during my round of meetings last year. We know that if we had better portfolio analysis tools, we could do this more easily, so we're working on that. But we also know that more regular and better interactions with key stakeholders will help us. So we have started by focusing on the U.S. Preventive Services Task Force. We will start working with other groups as things evolve, but we want to get input from those people. So we rolled out a new program to improve coordination between the Preventive Services Task Force and NIH several months ago after presenting it to Dr. Collins and the Institute and Center directors and getting their support. We have identified liaisons at each of the institutes and centers. We then identified experts for each of the topics that the task force works on. And we are regularly polling those people to find out what's the latest stuff that's going on that's related to each of the topics so that we can forward that information to the Agency for Healthcare Quality and Research, and so that they can feed that information on to the task force. We are getting a preliminary chance to see, an early chance to see reports, recommendations, evidence reviews from the task force. We have an opportunity to share those then with our colleagues in the institutes and centers and get their reactions so that we can have a better coordinated response when that material becomes public and can coordinate our response with the statements that are coming from the task force. So these are some of the activities that we're doing with one group, and we hope to, over the next couple of years, expand that effort and work with other stakeholders to identify needs in prevention research. The task force identifies needs in every recommendation that they release, even the recommendations that make perhaps an A recommendation, saying this particular practice is important, should be used, there's strong and consistent evidence. Even in those reports, they identify gaps in the research base that NIH can address. And certainly in their insufficient reports, insufficient statements, there are many areas identified that NIH can address. So we're going to be asking our friends across the institutes and centers to tell us, at least annually, what they're doing in those areas so that we hope to prompt additional work and so that we can share their answers with the institutes and centers. The third priority is very near and dear to my heart. Those of you who know me know that I'm a methodologist. Many people think I'm a statistician. I am not, but certainly have a very strong interest in methods and statistical methods, and have worked in group randomized trials for many years. It was my experience as a grant reviewer and as a chair of a study section that NIH didn't always put the right people on study sections, at least in terms of methods expertise, and sometimes in terms of content area expertise. We're not going to fund the best prevention research if we don't have the right people on the study sections. So I'm very interested in helping to improve the education of the scientific review officers at CSR, improving the education of the program staff who advise many of your faculty, especially the junior faculty who have lots of questions about how to write research grants and how to present them. We're interested very much in helping the program and review staff get up to date and stay up to date on prevention science methods and have access to experts in prevention science content areas. We have approached several professional societies to ask for help in conducting what amounts to a survey of their members to document expertise in research methods and in content areas. And in fact, the Association of Schools and Programs on Public Health launched this survey just 2 days ago, I believe. And we've already gotten a couple hundred responses to it already. There are 15,000 members, and I'm looking to the deans and program directors to encourage their faculty to go online in the next few weeks and fill out what amounts to a 10-minute survey. These data will be tremendously helpful to us. CSR is very excited about the idea of having an electronic Rolodex that they can go to when they need an expert on structural equation modeling, or when they need an expert on econometric methods, or when they need an expert on some other prevention science method, or when they simply need an expert on adolescent health or an expert on addiction science. I was rather surprised to learn that they don't actually have that kind of Rolodex today. They have lists of different kinds. Some of them are electronic, but they don't have a master database that they share across all of CSR that has anything like what we're talking about developing. And they're very excited about the prospect of getting this. We hope to put this in their hands this summer once we have a large enough data set to feed into it. And so I encourage all of you to encourage your faculty to please go online, spend 10 minutes, and provide this kind of data. It's going to be easy for us to work with CSR and help get your faculty on the study sections, getting them important experience, and helping to ensure that we have the right kinds of methods expertise represented on prevention science study sections. We're also going to be working to develop training opportunities more generally, not just here at NIH, but for the extramural community. These could be workshops that are attached to national conferences. They could be summer institutes. There are a variety of things. We haven't settled on the details here yet. And we look forward to working with many of your faculty who could become instructors in these training programs. We look forward to working with those of you that have CTSAs where we can channel some of the resources with the CTSAs to develop perhaps MPH tracks that are focused more heavily on prevention science methods. Epi and biostatistics programs do some of that, but some schools and colleges have programs in clinical translational research, for example, which do even more of it. So I think there are opportunities for us to talk about ways to expand training. Priority 4 is promoting collaborative prevention research projects across institutes and centers. We are not a grant awarding group at NIH, so we cannot actually give out grants ourselves. We can contribute money to grants, but more importantly, we can pull the institutes and centers together and say, hey, we need some additional work in this area. Who wants to work on an RFA or some kind of an FOA in this particular content area? We're working on our first one right now in physical activity. I see lots of opportunity for us to convene program directors and program officers across the institutes and centers to develop funding opportunity announcements, to develop areas of interest in prevention research, and we intend to do that over the next 5 years. Strategic priority 5 is to identify and promote the use of effective evidence-based interventions. Now, we do not intend to reinvent the wheel. We intend to take advantage of all of the good work that many organizations have done, including groups like CDC or the Society for Prevention Research, who've identified effective evidence-based interventions. We hope to use our website and other tools to help point people to those programs and promote them. We hope to have Dr. Collins include in his standard presentations to groups everywhere examples of effective evidence-based prevention research, something that has not been part of his standard presentation to date. So there are many things that we can do that are related to dissemination, and we look forward to that, again, over the next several years. Our last strategic priority is to increase the visibility of prevention research at NIH and elsewhere. The National Institutes of Health are not the National Institutes of Disease. They are the National Institutes of Health. And prevention does not often get the same level of attention as disease treatment research, and we hope to increase the visibility of prevention research with our leadership at NIH, with the broader research community, and we will be using all of the tools that are available to us from the website to other kinds of things to increase the visibility of prevention research. We've already done that at NIH. The Office of Disease Prevention is a much better known organization in the last year and a half than it was previously. There's a lot more interest in what we're doing. We're starting to simulate activities, and with the approval of the strategic plan and the additional resources that we hope to get to help implement it, we anticipate doing even more of that. Now, I think there are lots of ways that we can work together. We're already working on the survey implementation. The association was very receptive to that idea when we first began talking about it, and many of you started inviting your faculty to participate in that survey on Tuesday of this week. I encourage all of you to do that. But there are many other things that we can do together. You represent collectively all of the colleges and schools and programs that are accredited in public health in the country. Our mission is to improve the public health by promoting prevention research. So there are lots of things that we can do. And I've identified just a few on this last slide. We're certainly open to hearing from you. Anything that you want to point us towards in terms of evidence gaps that you think need to be addressed, or research priorities that you think that we should take on or promote. We are looking forward to using the results from our survey to help put the right kinds of people on review panels and help us plan and conduct training programs in prevention science methods. You can certainly help us increase the visibility of prevention research, but I'm sure that there's a lot more. So I'm going to stop making comments at this point so that we have plenty of time for questions. I understand that you can submit questions by typing them into the chat facility that you have available to you from the webinar, and the folks here can see the questions that you're providing. I'm happy to take on any questions that I can.
Thank you, Dr. Murray. The first question we actually had come in is the Office of Disease Prevention collaborating with Mccory, especially in regards to the method development for the strategic plan?
Mccory is very interested in methods development as it's relevant to their activities. I have been talking to the leadership of their methodology committee, and so those conversations are underway. They haven't been extensive to date. Our strategic plan was approved 2 months ago, so I hope you'll give us a little honeymoon period to get things going. But we are in touch with them. We have been talking with them, and we will continue to do that.
Okay. So I think there's one here that I think many of us speak for the public health research community when we say that we're pleased that NIH has produced a strategic plan with its strategies. But unfortunately, it comes at a time when budgets, the NIH budget specifically, is stretched very thin. How will you find the resources to ensure the strategic plan is actually fully implemented?
I can share with you that Dr. Collins is very supportive of what we're trying to do. I know that words are easy and action is more important. And so within a few days of having him approve the strategic plan, we submitted a resource request for additional resources for our office to help us implement the plan. We don't have a final decision on that yet, but I'm very encouraged that we're going to get a lot of what we've asked for, not all of it by any means, but I believe that we will get additional resources. We will never, though, have funds to pass out as grants or as contracts or as collaborative agreements like the ICs do. They will continue to be the groups that make the awards and manage the awards. What we can do with additional staff and additional resources is serve as a convening group. We can help pull people together around public health research topics that are of interest to the prevention community and make sure that we have RFAs and other funding opportunity announcements in those areas, and that the institutes and centers take those areas seriously and include them in the things that they fund. We're doing that now with our first initiative in physical activity. I look forward to many, many more. I've learned since coming to NIH that as an office in the Office of the Director, we're in an interesting position. The Office of the Director is something like the Switzerland of NIH. We are seen as a neutral party without a vested interest in one disease entity or another, or one particular mechanism or another. And often institutes and centers, as I have learned in my conversations with Bob Kaplan at OBSSR, are willing to sign on to FOAs and other funding opportunities if those opportunities are led by an office in the Office of the Director, as opposed to being led by one of the institutes or centers. Especially if one of the large institutes is taking the lead role, sometimes the smaller institutes and centers don't feel like it's worth their while to get involved. But we can do that as an office in the Office of the Director, and we've had a terrific response with the physical activity effort, and we anticipate more of those.
Here's one here. How does NIH coordinate with CDC on prevention research, specifically activities like the Prevention Research Centers?
The Prevention Research Coordinating Committee is a trans-NIH committee. There are a number of committees like this. There's one in AIDS. There's one in behavioral and social science. There's one with women's research. The Prevention Research Coordinating Committee includes a representative from each of the institutes and centers, includes a representative from CDC, includes representatives from other parts of the federal government, especially DHHS, that are interested in prevention research. We meet monthly. We try to coordinate prevention activities around NIH. We are watching very closely what's happening with regard to the Community Preventive Services Task Force and the Community Guide. We're watching with great interest what's happening with the Prevention Research Centers. We saw almost immediately that some of those activities had been zeroed out in the budget that was just approved. And we're very interested to see what's going to happen. I can't tell you probably more than you already know about what's going to happen, but we are talking with our friends at CDC. We want to try to be helpful. We can't simply step in as another branch of the federal government in the same department and say, oh, well, here are the dollars that you need to continue those activities that Congress took away from you. So that's not going to happen. But I do know that they are doing everything that they can to try to find resources to keep many of those activities going. We're going to try to be helpful as we can.
You talked about working with outside groups. Do you anticipate establishing a regular forum for their collaboration, possibly an advisory council like the institutes have?
Advisory councils are special, and to actually use the term advisory council, you have to have special dispensation from the secretary. I learned that the hard way because I called my working group for the strategic planning process an advisory council initially, and quickly was told that I couldn't do that. So creating these groups is difficult. There have to be very good reasons and a good plan for doing it. A couple of the offices have them. The Office of Research on Women's Health, for example, has a national advisory committee. We have talked about it. There are no plans at this point to try to organize one. We do rely on the Council of Councils for help and for advice. The Council of Councils is the advisory group in the Division of Program Coordination, Planning and Strategic Initiatives, DPCIPSI. They have representatives from the councils of each of the institutes and centers, and so they have very broad interests, and we go to that group and present our ideas and get feedback from them. So we do have an opportunity to interact with the council of that kind. I also make regular presentations to the councils of some of the institutes and centers, so I get feedback from them on things that we're thinking about doing. We have not, though, in direct answer to your question, made plans, at least in the near term, to create an advisory group of our own.
I think sort of there's another question sort of in line with that, which is I think the ASPPH's members are looking for a strong voice for prevention and population-based studies within NIH. And clearly, your office has the ability to be a bully pulpit for leadership in individual institutes, and who control $30 billion of NIH's budget there. And so I guess the question was sort of how will you sell that plan internally within NIH, which I think you just touched on a little bit.
Right. So one of the things that we do have as an office, though we're small and with limited resources, we do have a bully pulpit. So I have easy access to all of the institute and center directors. I meet regularly with Dr. Collins and Dr. Tabak and others. I'm considered one of the senior leaders at NIH, so interacting with these folks is straightforward, and we meet regularly. I sought their advice early on for how we could be helpful to their institutes and centers in terms of advancing the prevention research that they do. They were very open to that. I think they're going to be very open to the suggestions that we have. They embraced our proposal to expand the coordination activities that our office does with regard to the Preventive Services Task Force, for example. They've been receptive so far on the physical activity FOA that we're developing. So we do have a bully pulpit. We do have an opportunity to talk to people and to push good research ideas. So I invite all of you to let me hear from you about the initiatives that you would like to see NIH pursue in the area of prevention, in the area of public health, and we're happy to lead the discussion or participate in the discussion as appropriate.
We have a question here that's actually timely, since ASPPH's Hill Day is with members of Congress is next week. And the question is that the phrase prevention research is often unclear to people who aren't familiar with it, and in cases sometimes a lot of people in government, other parts of government, particularly in Congress. And so do you have any ideas of how to sell prevention research to people who aren't involved with our work?
Well, I think it's good to talk about the successes in prevention research, and the successes in many of them are easy to identify. There are lots of good stories that we can tell about the improvements that have happened in public health over the last 50 years. Much of it spurred on by research in the area of prevention. I think it's important to try to keep things at a reasonably simple level and not wander too deeply into arcane academic discussions. But the leadership, I think, is very interested in prevention, in improving the public health, in saving money to the extent that prevention can do that. So I think we've got a good story to tell, and I am talking with Dr. Collins and Dr. Tabak and others about how we can more effectively promote prevention research on the Hill. We have to be very planful in doing that, and it's actually far easier for organizations like this to interact with folks on the Hill than it is for individuals at NIH. But that's certainly something that we need to be doing.
One question here was a challenge for schools and programs is to mentor new faculty in writing grant applications as well as serving on review panels. And sort of, I think this question is more specifically, how can they work with NIH to encourage talented resources to continue to participate in NIH work?
It's really, really important that people not get discouraged in tough times, and we are in a tough period right now. I don't recall the pay lines being this low before. I've been submitting grants for until 2 years ago for about 33 or 34 years, and the pay lines are just frustratingly low for all of us. Things are a bit better, I think, in 2013 than they were in 2012. I'm optimistic that they will be better in 2014. So I want to encourage folks to not get too low over the current situation. I hope that it's going to get better. We have a lot of friends on the Hill, a lot of friends in the administration. I think NIH has been seen in a very positive way for a long time. And as the economy improves, I think resources will flow again more freely towards public health research. In terms of specifically helping young investigators do a better job, you know, a key part is something that only you can do, and that's the mentoring that senior faculty can provide to junior faculty. I was a department chair for 7 years at Ohio State. I was a senior faculty member in the School of Public Health at Minnesota for years before that. I learned in a fabulous way. I apprenticed myself to people who knew far more about writing grants and doing research than I did. I really grew up at the University of Minnesota working with Henry Blackburn and Russ Lupker and others there, learning how to prepare grant proposals by working with them on the proposals that they were developing. They already knew how to do it. And so I would help a little bit here and there and learn the process along the way. So this is something that senior faculty in schools and programs in public health can do as a service to their junior colleagues. Put them on your grants. Get them to help you put the proposals together. Have regular meetings and workshops where you discuss applications and the pink sheets that you received after it was submitted, and perhaps the revised application that you put together the second time. So those are things that you can do. We are going to be adding sections to our website to try to make it easier for people interested in prevention research to identify the right study sections, to identify the right contacts at the institutes and centers who might be helpful in guiding young investigators who are interested in particular kinds of research questions. The program directors and the review staff can be very, very helpful, especially to young people who haven't worked in this process before. NIH also has an opportunity for young investigators to come to NIH and participate in a very gentle way in the review process. So they can come out and be assigned as a third reader on half a dozen applications with no major writing responsibility on any of them, and learn about the review process that way. So that can be very helpful. We're very happy to try to help identify young people who can serve as reviewers and get them involved in that process. So if you have candidates that you would like to suggest be involved in that process, you can get in touch with our office.
Great. The next question here is, can you elaborate a little bit on the programs offered by NIH to recruit and retain underrepresented minorities to the research field, particularly the public health research field?
NIH is launching a major new effort in this regard. At our leadership forum a year ago, we focused on two big areas, and one of them was the research workforce and the need to do a much better job than we have been doing, both in recruiting underrepresented groups to NIH directly in terms of the intramural research program and staff here on our campus, but also in terms of trying to encourage and make it easier for underrepresented groups to be involved in prevention research in the extramural community. So there's a whole new series of grant awards that are going to be available very soon that will allow institutes or universities, colleges that represent underserved groups to partner with more experienced groups and develop a coordinated mentoring effort to try to help the faculty in the groups that aren't as active in research to become more active. So that's a new effort. A variety of new initiatives that are coming out of this discussion at the Leadership Forum a year ago. I'm not actually sure if those grant mechanisms have been announced yet, but if not, they will be soon.
Great. The next question is a little bit more, to go back to methodological tools, what you were talking about at the beginning. Folks were wondering if since the plan calls for more support for developing better methodological tools for prevention research, if you could speak to that a little bit more.
There are a number of FOAs that are out on the street now that encourage methods development. We are reviewing those with an eye towards what are the areas that aren't covered adequately so that we can put an FOA together to support the development of methods research. There is growing interest at NIH in research methods and the need to do a better job in training extramural investigators in the best methods and then in using those best methods. This is prompted in part by the reproducibility or lack thereof discussion that's going on, both in the scientific community and in the popular press. When a large fraction of the published studies can't be replicated, that doesn't make any of us look very good. And we've had lengthy discussions here at NIH about things that we can do. Dr. Collins published with Dr. Tabak a piece that was, I think, in Nature recently on specific steps that NIH is planning to take. And one of them is to try to focus more on encouraging training in research design and research methods. So our interest in promoting prevention science methods is very consistent with that. And we're going to piggyback on that as much as we possibly can. Our initiative, our priority 3 is to encourage the use of the best possible methods in prevention research and develop training opportunities for existing faculty and graduate students in prevention science methods. So we will be in touch with many of the schools and programs in public health about getting involved in that activity as it develops over the next couple of years. We had some very interesting conversations early on with the director at NCATS about it, and the director was very open to that, and so that's an example of the kind of thing that we may do.
Dr. Murray, I want to follow up on the question about methods and tools here a little bit. Clearly, one of the most powerful tools coming into the portfolio is the use of big data through very large new technology capacity things, and it seems to overlap very much with what you want to do advancing population-based and prevention research. Can you talk about any role which you will play within NIH on their large big data initiative, and in particular address the issue of possible common tools necessary for people to take advantage of this in the public health and prevention research community?
Right. I have not been terribly active with that initiative to date, but Bob Kaplan has been. Bob is the director of the Office of Behavioral and Social Science Research, one of the sister offices along with us in Deep Poughkeepsie. So Bob has been more active, and he and I have been staying in touch about it. NIH is putting substantial resources into the development of tools to help us use the voluminous amounts of data that we have available to us now, the sort of the big data problem. We've definitely moved, we think, into the circumstance where big data is a problem for us, and we need better tools to deal with it. So NIH is putting resources into that. Some of that has to do with better tools for processing text in a variety of ways, content analysis in a variety of ways, lots of things. And so we are very interested in it. We're keeping an eye on it. As we get additional staff on board over the next year, I can see us playing a more active role in the group that's working on the initiative at NIH. So we're certainly aware of it. We're certainly interested in it.
Yeah, so I think we have just kind of one last question, which you touched on at the end of your presentation, but just to sort of wrap up, I think, which was how can ASPPH members, again, sort of work best with you to move forward and to help move the ball forward for this plan as a real tool for change?
There are a variety of things that you can do. Certainly, if you've looked at the plan and you've got ideas for things that we should do that are consistent with our priorities, and you've got specific ideas about things that we can do, let us know. Talk to us. Send us a note. You can, the last slide in the set, which I haven't actually put up, has our, am I going the wrong way? Yeah. There's our email address. Send us notes and messages anytime. You can send them to me or send them to the office. So we're always happy to get specific suggestions for things that we could do or initiatives that we could pursue. I've already encouraged you to encourage your faculty to participate in our survey so that we can help put the right people on study sections. You are in a position of talking to your legislatures and to members of Congress about public health and about the importance of prevention research in ways that we can't as officials at NIH. We're federal employees, and so there are substantial constraints on the kinds of conversations that we can have. But you don't face those same constraints. So that's an area where you can do things that we cannot do. So these are just a few areas where I think we can work together. We're very interested in hearing from you about initiatives that you'd like us to pursue or like NIH to pursue. If you want to write to me and talk about problems that you see at NIH, things that we're not doing well, things that are hurting public health research or prevention research because the NIH process is somehow broken or not working very effectively, let me know, because we have a chance to try to do something about it and try to fix it. Again, it's easy enough for me to pick up the phone or walk into someone's office who's in charge of whatever that is and talk to them about it. So one of the things that I'm getting ready to take on is I want to start talking with our friends at OER about the conflict of interest rules and the difficulty that that's creating in terms of putting people on study panels, because there's so many constraints about you can't have any sort of connection to anybody else whose application might be reviewed. There are process things like that that may be very problematic from your perspective. Let us know. It's one of the kinds of things that we definitely can do as an office is try to fix the processes that NIH uses that currently aren't being as helpful to prevention research as they could be.
Thank you all for joining us today, and thank you again, Dr. Murray, for your presentation and all the information you provided and shared with us today. For everyone online, if you would like to obtain CPH continuing education credit for this webinar, please enter the passphrase prevention plan, one word, in the CPH recertification and reporting system where prompted. Also, please be sure to contact us with any additional questions and to register for the next webinar in the ASPPH Presents series, Diversity as a Vital Component of Health Systems Change, featuring Dr. Mark Neve, the Chief Diversity Officer at AAMC, which will take place at 2 p.m. Eastern Time on Thursday, April 24th. Thank you.